Population health is a big buzzword that you've been hearing a lot, especially the past few years in the healthcare industry. Its popularity really has increased as the Institute for Healthcare Improvement has included it as part of its triple aim, which CMS has also greatly promoted. Depending on who you talk to, you may hear a different definition of what population health means, but it generally focuses on the improvement of health outcomes for a group of individuals. As you may know, there's various payment reform and value-based care models, which are often risk-based, such as ACOs, that have formed. And this is really especially in light of MACRA. These models are finding more effective and innovative ways for improving health outcomes. And at the same time, there are also various approaches to help drive better outcomes, such as disease management, care management, lifestyle management, and so on. However, the very basis of population health is data. Data management and health information technology play a key role in helping toward advancing these interventions through tools such as EHRs, registries, telehealth, precision medicine, genomics, and so on. We're very privileged today to have a diverse panel of speakers representing different perspectives who will share with us how they utilize data and HIT towards advancing population health outcomes for their respective stakeholders. Now we get to the fun part of the session, the question and answer. So we have a series of questions that we'll go through with the panel and really have it be in a conversational format. And we'll leave about 10-15 minutes in the end to answer any questions from the audience. So without further ado, each person on this panel has, as we mentioned, diverse background and area of expertise. So I'd like if you can each address, how do you use technology in your respective area to approach population health? And who are the key stakeholders who use it and how? I know this could really vary too, in the type of population, if it's Medicaid, commercial, and whatnot. So Tom, would you like to address that, please?
Sure, I'll give that a try. So at Coastal Lab Partners, we're not the typical lab. We actually don't do any fee-for-service work. All of our clients are either commercial research organizations or managed care organizations. And this may sound strange, but we use data to try and reduce and pinpoint the number of labs that actually get performed in these organizations by identifying the patients who are actually going to benefit from genomic research versus the approach some of you may have seen on Facebook, Twitter, and other places where people are encouraged to go out on their own and get genomic testing, sometimes without real data context or at least a clinical context or phenotypic context for those results. So our approach is to use AI and other tools to actually identify people who can benefit from genomic testing versus suggesting that everyone in the universe should go out and be tested.
Great, thank you. Dr. Deapen?
As Hela pointed out, I'm a cancer epidemiologist. My son works in artificial intelligence at Palo Alto, and we both think it's hilarious that I'm on a panel for artificial intelligence. But I'm here to represent the California Cancer Registry, which is the California Department of Public Health's program. Every state in the United States has a program to identify and report every cancer patient in the state. And so the California Cancer Registry performs that function. I represent, out of USC, I represent the Los Angeles component of that. And the way we use technology is the providers, the diagnosers and treaters of cancer patients are required by this law to report a set of information about each cancer patient to our program and do so electronically. And I'll just jump right into why I'm here, actually. The way, and of course these days, all of that information is in an EMR. The way they all do it is they hire a person to go into their EMR and type variable by variable, patient by patient, all of the information that's in their EMR into a different electronic data set and send it to us through the internet. So we are well behind any technology in terms of that, with one exception, and that is what we do have a program, and it's going to be expanding next year, 2019. The legislature modified the law, and it's going to require submission electronically of the pathology report. So 96% of cancer patients have a pathology report that defines the diagnosis of their case. And so those are going to be submitted electronically. A key advantage of that is the manual process I just described takes months. So we're getting these reports months after the diagnoses. These path reports, of course, are the defining moment of the beginning of that diagnosis, and so they can be submitted electronically, and they will be submitted electronically. Los Angeles already does this for the most part, but even then, it's a bunch of text. And so then I have to hire someone to read them and code them to identify what kind of cancer, et cetera, et cetera. So great opportunity for artificial intelligence to do that instead of people.
Great. Thank you, Dr. Deapen. Ash?
So I guess I rambled a bit earlier today about how we at Lumiata use technology, but I didn't talk a lot about to whom we work with. And part of whom we work with is a number of different ACOs. So for example, we work with the folks at Universal American, now called Collaborative Health Systems, which was recently purchased by WellCare. And they basically run or help manage around 20 odd ACOs, right? And so when we talk about really technology use, especially when we talk about pop health, my mind immediately sort of goes to sort of my experiences of how this has actually been deployed and actually become very effective, where what we've deployed for them is actually what they use literally on a weekly, if not daily basis. And what's interesting there is, you know, we take all the data that is generated, so CCLFs happen to be in this particular case in terms of ACOs, lab data and demographic data, et cetera. And what we're really doing is helping them generate the list that they need to understand what measures have been done, what measures have not been done, what measures should be done, and how do you prioritize that. Sort of talking a little bit back to what I was talking about this morning in terms of healthcare kind of runs on lists. And so what we're really helping people do is generate those lists, distribute those lists, and then allow them to actually take action upon those lists to actually go ahead and help people deliver better care. And this is really sort of done and delivered from a technology-enabled service, right? That's really what's going on. I mean, for both these two instances, at the end of the day, towards sort of what you mentioned, the lifeblood of all these processes happens to be data, right? Data to identify to whom we should be getting testing, data so that we can understand what's going on with folks so we can get them the right resources that they need, right? Data to help providers be more targeted and engaging with their patient population. So that's kind of how we've used data.
Great. Thank you, Ash. And you and Dr. Deapen, you've touched upon it a little bit, but really when it comes to data and the various sources that you use, it very much becomes important what those are. Are you getting claims? Are you getting pharmacy, ER data? And in particular, how timely is that data? I do know, just drawing upon my experience having run ACOs, and as you've referred to it, creating lists, for example, to risk stratify patients based on these data sources that we have. But some challenges that I know I've encountered in the past is the timeliness of data and being able to get real-time data, for example, to when a patient is to find out they're in the ER, timely enough so that you can have your care management team follow up and be able to prevent that readmission from occurring again. So if you can each speak, and maybe we'll start with Ash, since you just started speaking to it. What data sources are you using, and how do you ensure the timeliness of the data?
Well, I think this question was also asked when I was speaking earlier as well. The data is generated and captured and distributed at very different frequencies. I mean, claims data, we can all agree, is probably from the time of when the service is being applied to the time when that's actually even sent to the payer is already potentially weeks, and then the time by which that is actually finally utilized maybe weeks further, right? So you're talking literally in the orders of months. Right, but there are many other data feeds which are at a much higher level of frequency, right? We were mentioning a bit of lab data. If you can get the direct feed from the pathology or the LabCorp request or et cetera, you can literally, that's, that day, that moment, same thing from fill rates from pharmacy. And then you also have ADT data as well. So what we have found is you really need to leverage a conjunction of different data sources to sort of start to address the issue of timeliness. There are entire companies whose focus is how do they make the distribution and the delivery of ADT data much easier and able to therefore flow to a variety of different organizations, right? There's, companies who built entirely around how do they make lab data more easily available. We see SureScripts as another example from the issue of data for farm. So I think you'll see the continued emergence of more and more data aggregators, but also data facilitators from the issue of ensuring timeliness of data, because that has a dramatic impact upon the relevance of what you do. Especially as we start thinking from a behavioral perspective, there's a lot of studies that, if you're able to engage people at different time windows, your likelihood to actually affect meaningful change for that person is dramatically different. And so without having that timely data feed, you're going to miss those opportune windows, which is actually very unfortunate. So it's actually something of great importance.
Yes, thank you. Dr. Deapen?
So as I described, in our use and collection of the data, it's a little bit of a tricky answer to your question. That what I'll call the complete data set or data report is required for each patient, includes capturing the first course of treatment provided to that patient. And so by definition, that doesn't happen on day one or week one. And so there's an intentional delay, if you will. And then there's the unintentional delay of all this manual work that happens that could be automated. And that's why we're going to this two-tier system, because with this new innovation in January, we will have real time. And that's really exciting to us, real time. And what that allows the state to do is, while we don't have all the information that we're going to know about that patient, we know what is happening in cancer in our state every single day. If we do it right, we'll know everyone diagnosed with cancer yesterday and before, so that we can really monitor, very precisely what's going on. And coming from a research university, researchers, while they like all that information we collect 4 to 6 months later, depending on the nature of their research, if their research, say, is focusing on treatment decision-making, they want to collect that information when treatment decision-making is going on, not asking folks to recall, you remember what that was like? And they don't. Yeah. And so this will enable a whole new set of research opportunities by having this real-time reporting.
Oh, that's great. It sounds very exciting. Tom?
Yeah, so what they said in terms of sourcing the data, I guess I'd highlight for a smaller organization one problem. I spent some time in the financial services industry. Claims data is great because it's consistent. It's late, but it's consistent for the most part, where clinical data, especially for where we are, is challenging at times. There's this notion of harmonization in financial services that just doesn't seem to exist out there in the world of clinical data. Or at least it's getting better, but it sometimes is quite challenging to put together different data sets that appear to have the same data but don't. And I won't go into examples. For the genomic space, I think the additions would be, we obviously pick up data from translational databases that are matching histograms and other things to words in English that people can understand. And then more and more these days, the annotations or the updates that are coming from genomic research are pretty important, and it's pretty important that those get into the provider workflow and ideally get in the face of someone who knows how to interpret that small change in how a gene or a mutation is being interpreted and whether some other change should occur in terms of the treatment as a result of that information. And I think that goes to the example of things are changing, but the systems that are out there are not quite ready to ingest that kind of information, which comes in huge volumes of data, but is hard to break down and make useful.
Great. Thank you. So just on that same topic of data aggregation and what sources are used, I wanted to add a extra layer, something that's been discussed a lot recently, more than it has in the past, and that's what they're referring to as social determinants of health, so social, lifestyle, or observations of daily life. Factors, again, that are not the standard data set that have been used in the past. It's starting to be incorporated a lot more, especially as we talk about the Medicaid and the low-income populations. So I'd love to hear from our panelists on how, if at all, you've been able to factor in those social determinants as part of your population-based health approach. And Tom, maybe you want to start.
Sure. We have a package, we call it Geneticision, and that's the Predictive Analytics package. I wouldn't call it an AI package. And one of the factors that's in there, I think they call it lifestyle in most cases. And I'll give you a practical example. So with pretty inexpensive genomic labs, you can determine someone's sensitivity to opioid absorption rates, so high, low, whatever. And that's often used these days in determining how to work with folks that are in a treatment program. What that doesn't tell you is anything about their lifestyle. And it actually turns out, and I have a friend that runs a pretty well-known outpatient addiction clinic, if that person is homeless, it doesn't matter how good our work is on the lab report or how good the provider is working, the treatment's probably not going to succeed. Unless they've actually got a stable place to live. And the second more interesting lifestyle factor was whether or not they had a mobile phone. And those were actually the two key indicators of whether treatment was likely to succeed in terms of either getting a person off the opioid or at least getting it managed over time. So I'd use that as an example of sort of technology crossing over with data, but where the technology or the lifestyle issue was actually more important than us figuring out that they were an ultra-rapid absorber of opioids.
Great, thank you. Dr. Deapen, did you want to speak to
Sure.
it?
It's been estimated that about 65% of all cancers are due to behavioral factors, lifestyle. And so, we don't collect the data just to count cases, but to try to impact and reduce the morbidity and mortality from cancer. And so, if 2/3 of them are due to lifestyle factors, the more lifestyle factors that we can capture on the population, we're in population health, the more useful those data are, the more impactful they'll be. So part of our challenge is, as I described earlier, most of our data, and I haven't talked about other data, but most of our data comes from the medical record. So what's in the medical record is what we have access to. So that's not everything, but it's a lot. We do link, though, with other external databases to bring in some of those whenever we can, whenever they're captured, even census data to describe economic and educational levels and this kind of thing, because they're all predictors of cancer. And what we haven't done, but we're talking about, and it's scary to some of us, or just kind of unimaginable, is we never talk to the patient except when there are formal organized studies of, say, a certain cancer in a certain location. There's not a routine communication with patients, so they don't contribute to their record in the cancer registry. But they know what we need to know,
Right.
and they don't have a pathway, even if they want to, they don't have a pathway to contribute that. And so gaining an opportunity for an interaction with the patients for them to contribute. Every cancer patient, when they're diagnosed with cancer, racks their brain asking the question, what caused my cancer? And they'll come up with some answers. And so to be able to capture that and learn from it, using some artificial intelligence, it would be a whole new world for us.
Great, thank you. Ash?
Yeah, for us, I mean, just like in any data set, we look for what is, high relevant signals. And as I sort of mentioned this morning, it's always fascinating to me from electronic health records and otherwise how we don't have a code for lonely, right? And we can tell from people know how that affects people from a cardiac perspective. We talked about how that also from the social factors and people's mental state, this sort of a feedback loop that happens to be there. And so, social determinants are basically things about our lives, our behavioral realities. It touches everything, right? And so the ability to understand, someone who's going to be, not, having issues with medication compliance is probably not going to be the most on top of it across a variety of other aspects of their life, right? And so it's not as if this one part is completely somehow separated from everything else that they do in their life. So the ability to pull in this type of information, I believe, is key for us to understand things before they cross certain levels of acuity, so that actually gives us the opportunity to intervene. It also tells us as to when and how and what is the right way to potentially intervene with somebody. For example, please don't call or email me. I probably will never listen to you. I just get too much of one and the other. Text me and I'll probably respond in about 20 seconds. Right, and so depending on who that person is, people have different dynamics, and also when and throughout the day that actually changes. So I think when I think about social determinants, I think it is very exciting for us to start incorporating it, but we also have to be very thoughtful about how do we collect it effectively in a way that's meaningful but respectful with people as well.
Yeah, thank you. You make a good point. So just moving forward then, I'd like to hear from each of the panelists as far as how did you develop and deploy the new technology toward advancing population health? And when you did introduce this, what was the receptiveness from your stakeholders? And to the extent that you can differentiate if there's a difference between when you're dealing with the Medicaid population, commercial population, or variety of different populations, if you can address that as well. We'll go ahead and start with Tom.
Sure. We have partners. I think that would be our answer, and one partner is Coriell in Philadelphia, and they're our translational database provider, and the other would be Ovation, that provides our lab information system that takes the order and where the sample goes in the well and make sure all that ends up being reported back out correctly to someone who's going to interpret the results. And I think not a very interesting answer probably to the question. But I think the more interesting thing is what we do with the result. And with that, we're working with some of the better known EMR vendors to make sure the data, make sure the order itself is based on evidence that's present somewhere, somehow in the EMR. And the more expensive EMRs tend to have ways to create workflow or worksheets or whatever they're called, so that the physician can be informed or something can be suggested as an order based on data that's there that might justify spending money on a genomic or a genetic test. But I think the bigger challenge, assuming the test gets ordered, is the data comes back in. And it, first of all, it can be voluminous data. The typical primary care physician does not have hours to read through all of it and click on all the links to the various footnotes. And I think a major challenge for the genomics testing space is to communicate that data back to the provider in a way that's actionable, and if necessary, where they can drill down just enough to support the treatment that they're going to recommend. So.
Great, thank you. Dr. Deapen?
So I'll answer that, continuing in the context of this electronic
Yes.
path report capture. We actually introduced that in Los Angeles about 16 years ago. And until next January, it was on a voluntary basis on the part of the hospitals. And so I actually had to go out to the hospitals and convince them it was in their best interest to do this. And by this I mean install a software in their pathology LIS that would identify the cancer patient path reports and transmit them to us. And there were a variety of reasons why it was to their advantage. And so it was really just working through the legalities, data protection issues and all that. It was facilitated by the fact that it is required by law to report the case. So I didn't have to sell anything. And it was also facilitated by the fact that the National Cancer Institute paid for it. So they didn't have to pay for anything. And so we just went hospital by hospital, and it was kind of a domino effect. As the big hospitals adopted it, that gave comfort level to the other ones, and that's the way it moved through to, as I mentioned, I think earlier, 3/4 of the hospitals now in LA already do it, and so the remaining ones tend to be the small community hospitals, and it's going to be a bit of a challenge for them because they're the ones that have the small or non-existent IT departments. And so while we do have this system that works wonderfully, just getting it introduced and functioning, we're going to have to hold their hands to move forward with that.
Okay, great, thank you. Ash?
Yeah, I mean, so in a lot of ways, the work that we do we don't directly create interfaces for those with the different populations, but rather what the stuff that we have done is work with providers. And so that in some sense is the user base for some of the work that we've done with respect to population health. And specifically, as I was mentioning, with the ACOs that I was referring to earlier. And in some sense, what we try to do is we try to make it like TurboTax, right? Make it really, really simple. It was interesting. I had been invited to go speak they have the physician leadership group that occurs, I guess, yearly. And about a year and a half ago, I got invited to participate in their in the whole set, the 20 different odd ACOs physician leadership group. And I was told something very strange. They actually liked the piece of software that they were using. I've actually never heard physicians say they like software. So
What a concept.
This was fascinating. I was kind of, befuddled. But, what they liked was that it was actually just very simple and to the point. It got them what they needed to. And in some ways, they were as part of sharing in the savings or sharing in the upside, there was also a financial relevance to them. But at the very least, it was something that they were very confident would allow them to cross the street, as I say every day. And I think that sort of robustness, simplicity, they liked it. It was effective, got them what they needed. And so, I think at the end, I jokingly say when we think about pop health and we think about data and we think about technology, remember, physicians and people on the healthcare side are people too. And the same dynamics, the same issues that are there in any consumer product are there. And in some senses, they're magnified because of the complexity of the situations that people are in. Right? I mean, I jokingly say EHRs are death by checkbox, but when you try to not enable people to have the set of options that are actually there, they're not able to complete their day because the reality is healthcare is complex. And so, I think we just really be thoughtful about both those points, and as things are evolving and hopefully as systems get smarter, you can go ahead and create smarter interfaces so that therefore it's anticipatory. Hey, I already know that given the context of this patient, the most likely thing are these following 5 labs. The other ones are, have a greater than 60% chance of likelihood, and the other ones over here, less than 2%. So unless the person specifically requests that, no need for that, right? So there's ways you can be smarter about creating interfaces through technology, and I think we'll start seeing that, but it is, definitely a challenge.
Great, thank you, Ash. You touched upon challenge, and I think you all have in some ways addressed some of that, but I did want to focus a little bit about that. I know when you're creating innovations and new technology and trying to implement it, with various populations and within different systems, you can often get pushback. Dr. Deapen addressed the fact that some organizations are much larger scale and have infrastructure versus others are more mom and pop and don't necessarily have that infrastructure. So if you can just each address in your experience as you've implemented these new technologies, what challenges have you found, and how have you worked to actually overcome those? Tom, did you want to go ahead?
Sure. I would say our biggest challenge hasn't been technology. It's been the way that laboratory business has been conducted, at least in the cutting edge areas over the years. And I'd focus on genomics specifically because it kind of tracked to the toxicology space, which doesn't always have the greatest reputation out there, but where the focus was on, here's a test that costs a lot of money, where you can make a lot of money if you're in that business, and volume is the key thing to drive it. And I saw that as an opportunity for us, because I don't think that's actually the way to make genomic lab work sustainable over time, whether you're talking about the kind of stuff we do, which is sort of at the low end of the technical scale, or the folks doing whole genome at the higher end of the technical scale. The business model itself was the biggest challenge and is the biggest challenge today. As a result, you have health plans routinely denying genomic tests that actually would make sense, because they're just suspect across the board, and that's driven by a lot of different factors out there, but it's mostly driven by the fact that volume it was the main driver of PCR-based genomic testing. And I think the way to address that is to make it evidence-based, work from the data, if you can get the data in a way that helps support the decisions, and show that there's a pretty clear benefit, both to the economics of healthcare and ultimately to the patient. So that's my answer.
Great, thank you. Dr. Deapen?
And before I respond, I'll just point out the State Health Department sent a couple of representatives, and they're at the booth right outside the window there
Oh, great.
that may be being taken down as we speak.
Rush over there if
Rush
you
over
want to
there
go catch some.
if you want more information.
Yeah.
So I kind of touched on that a moment ago. The pushback was actually appropriate in my, so that's the wrong use of the term. The due diligence. So
Okay.
many of these facilities, I had to meet with 4 different units to introduce this: administration, legal, pathology, and IT. And they all needed to know about
yeah.
this
Right.
to come to a proper decision. So it's not, hasn't been pushback. This sort of this last push now, again with the smaller facilities, for the reason I already said, there's a level of anxiety. They haven't yet fully heard my message that I think it doesn't need to cost them anything, and their
Yeah,
cost is their primary concern. I think we've convinced them that it's legal, that it's safe, and it's good for their patients. And so pushback hasn't really been much problem, but again, I have the benefit of the legal mandate.
Yeah. No, that's great. And Ash?
Yeah, so first of all, I will agree. Legislative mandate is always helps. Right?
Yes, that helps.
I mean, even when we do things that we had worked on for the ACO with respect to measures, it's a mandated reality. That's the reimbursement model, right? So I think that's something to be very cognizant of. I think your points of cost are also very, very there. In a lot of ways, it's actually not the technology itself. That's usually rarely the barrier. It's the political reality. It's the cost reality. It's the, is it legislated or not? How can you actually prove value both economically as well towards your point, but also to the patient as well? So I think when, and this has been a learning for us, it's beyond the simple technology problems. It's an issue of you have to really think through how it is you help solution something for our customer that allows them to get through a variety of these other activities that are there to enable them towards success. And it really also requires the will of your customer to be successful. Change is not easy. I mean, I would always, when people are talking about, oh, we have a health system and we're going to, a couple of years ago, we're going to set up a EHR. I'm like, that's like heart transplant surgery. It's like, it's easier for you to buy the building across the street, put the EHR there, and have people start moving across. Higher likelihood for success, because the reality is where people are. There's an inertia of how things work. People are people. I mean, like, let's be honest. At the end of the day, as I said, they're not different than the rest of us. So you'd really be thoughtful about that, and those are the I would say the insights that you need to actually enable technology adoption. Actually, it has almost nothing to do about technology.
Yeah, no, that's a very good point that I think has come across from what each of you have said. I think also mentioned upon government mandates and programs, and those are also constantly changing. So as you're trying to get yourself, especially when you're speak from my experience being on the operations side and implementing, programs that are coming down from the government and they're shifting as you go along. That could definitely be challenging. And one big thing that has come out recently is MACRA. That's a word we keep hearing everywhere: MACRA, MIPS, APMs. And MACRA really has changed the way how CMS is reimbursing providers and really having a focus on, cost-effective quality care. So in light of that, I just wanted to see if any of you on the panel, what your perspective is on MACRA. Have you been involved with any technology that's helped support MACRA implementation? And if so, what challenges have you experienced with that? Has that varied across the type of organization you may have worked with?
Actually, I think Tom may have quite a bit of insight on this one.
Okay. Tom, please.
Right, yeah, this is not directly related to genomics, but one problem I've certainly seen from other things I do is the ability to meet the reporting requirements and then some of the, what do they call it, advanced clinical, something, ACIs, is especially difficult with contracted physician groups that are part of either a large, medium, or small hospital, where when they're not at the hospital, they're somewhere else, and they may or may not have an EMR there, they may or may not have the tools to actually report on their activity there. And so I think it's a problem and an opportunity at the same time. I think the larger hospitals, systems, health systems that probably are using Epic or Cerner could be creating virtual MSOs to extend that out to those groups if they could make it affordable, which is a big challenge, I think.
Right.
Otherwise, I actually would predict, but no one in Silicon Valley would fund this probably, there will be a business very soon in providing virtual MSO or MSO-like services to support all the MIPS and macro requirements
Yeah.
for medical groups that are affiliated with major health systems and for what remains of independent groups out there. I mean, this is not easy stuff. I mean, just someone here was at a meeting at CMS. It's very complex reporting, somewhat challenging. They're not straightforward APIs. Again, good opportunity in Silicon Valley, but probably no one will jump on that one. So I think it's a very interesting business problem
Yeah.
that someone's going to
Yeah.
solve.
Yeah, definitely. Thank you, Tom. It was brought to my attention we are getting close to time, and we definitely want to give enough time to allow for members of our audience to ask our panelists some questions. We're able to address a lot of interesting and get to hear some great perspectives from each of the folks on our panel.